everyone that is tuned in. All our doctors and our nurses from across South Africa, all our 9 provinces. We've got everyone in the house this afternoon. Thank you so much for joining us, where we commemorate the World Trauma Day today. And we want to thank each one of you working in a trauma setting, working in emergency, wherever you are. We want to thank you for the hard work that you put in to really be out there and save the lives of our patients. We commemorate this day, and we take a moment to appreciate the work that you do, and we also take a moment to appreciate the devices that's there to help you save the lives of our patients. This afternoon, we've got a wealth of knowledge on our panelists. We've got our managing director, Mr. H Villiers. We've got Dr. Willem Smith. We've got Dr. H Lategan. We've got Dr. Jonathan King, and we also have Gabriel Bruver, which is our R&D manager. And we thank you, everyone. We thank you for your time this afternoon. We are hoping that we can share as much information as possible, and really keep it interactive. And please feel free to post any questions that you have in our chat. We will discuss them towards the end of the session. But please stay tuned and enjoy every moment and take everything in that we are going to share with you. Chris, I hand over to you.
Candice, thank you very much. You introduced everyone other than yourself. Do you?
So right. So I would like to introduce myself. I am Candice Williams. I am the Sinapi rep for Western Cape and Eastern Cape. Thank you.
Excellent, Candice. Yeah, thank you everyone for joining, and it's for us also as a private company, privileged to be part of or to partake in World Trauma Day. So quickly, Sinapi Biomedical developed a Sinapi chest drain that's used in South Africa, was developed in South Africa, and is now used in more than 50 countries in the world, both in a trauma as well as a cardiothoracic setting. So after cardiac surgery, after lung surgery, the fluids are drained from the pleural, mediastinal, and pericardial spaces, and then the patients recover after that. But just to quickly mention, so the topic today is difficult trauma cases, specifically chest trauma. And for me I just wanted to take 2-3 minutes to share with you the story behind the Sinapi chest drain. So we started with development 2004, 2006. Prof. Tim Hardcastle was involved at that stage, Dr. Dennis Allard, and many more trauma surgeons in South Africa. And then we refined that product, and we started using it in South Africa. And then we modified it further and took it international. And that's where I think we must be sitting at about 30% market share in Germany, for instance, as an example. So this product that was developed here in South Africa by trauma doctors is now used in quite a few places in the world, which for us is a really great story, and we are very grateful for it. But the interesting thing is, when we work with international doctors, they would often refer to how well, obviously in South Africa, you guys, the trauma surgeons, see so much, you've got such a high level of trauma. So that we would often hear the comment, this must have been the right country to develop this product in. I think it is, and it's for us. We have such a respect for your skills, and having been able to tell us this is what a chest drain should look like. It should enable patient mobility. It should show you indicators to show you when the lung is expanded, because we don't have the resource to take patients to chest x-rays all the time. It should allow patients to not sit in or lie in a bed, but sit out in a chair, for instance. So a lot of the basics, and then later on, obviously, the auto-transfusion function is also important for you. So, just to briefly, without taking too much time, it's really a homegrown story that started here. And we're grateful for what we do here. There's still some work to do in terms of clinical research going forward. But a lot of the rest of the countries that we sell it in look at South Africa as the start of this device. Gabriel, do you want to quickly share a minute or two just in terms of what we do in terms of a design and development process?
Yeah, sure. Thank you, Chris. So what is R&D? In Sinapi, it's very much about solving problems, and those problems typically come from the market. Guys such as yourself that work on the front lines, work with our devices, and we come up with ideas typically by you know, our salespeople talking to the market and bringing those ideas in. That basically boils down to defining user needs. What is the requirement from the user? We then distill that into technical requirements. So what do we need in the device to satisfy the user needs? And then we come up with concepts or solutions to you know, to satisfy those requirements. And at the end of the day, we need to validate the solution and make sure that it's safe. We have a risk assessment which we need to do. We follow the ISO 13485 design process, which forces you into taking into account all the various risks. I just want to touch on you know, something that we really try have as a culture at Sinapi is continuous improvement of our devices. So we're not satisfied with just being okay. We always strive to improve safety, improve specifically, and a big focus on the ability for the healthcare provider to improve patient outcomes. And that's really what we pride ourselves in, and what I think one of the things that makes us successful in South Africa and overseas is the focus on the healthcare provider itself, to make life easier, to you know, make it easier to diagnose and treat patients. Oh.
Good. We look forward to hearing what all the interesting cases of the real champions in this webinar, and that's the doctors that need to make sure patients get better.
Yes, absolutely. Before we hand over to Dr. Smith, I would just like to present an apology from our sales manager, Dr. Magda Botha. Unfortunately, she couldn't attend the webinar in person today, but she is online, but she is not presenting or speaking. So her apologies to everyone that she's not able to attend. Thank you very much.
All right, good afternoon. I'm Dr. Willem Smith. I'm based in the Northern Cape of South Africa, being the vastest province, but with very little resources. So we span, in terms of our team, spans up to Springbok Hospital, and we cover the western part of the province. So most of our trauma cases are penetrating stabs. Most of them on the left side, and most of them we treat with a Sinapi drain. We're very fortunate now in our district. Most of the hospitals actually have it available, and most of the patients get Auto-transfusions, most of them. And because we're so fast-stretched, blood resources are very scarce, and this is why we love to use this drain. That's just one interesting story I can just share with you, just to basically confirm the safety features of the Sinapi drain. There was one patient that we stab chest again. We put in the drain, and then the patient decided to go home. He actually just decides himself, and we tried to get hold of him, but he didn't come back. He came back after 5 days, still with the drain inside too. And we actually asked him, so was there any issue, any problems? He said, no, we just want this thing out. And remarkably, once we removed the drain, there was no complications. So as a surgeon, we try to save lives, and we try to alleviate suffering. And in terms of the Sinapi drain, this basically do the same for us. It helps to save a life, and it helps to save blood resources, especially when we're sitting with very little resources. But yeah, that's my story.
Wonderful. Thank you so much. That's very good to hear, Dr. Smith. Thank you for sharing that. Do we have any questions for Dr. Smith from the panelists? Having a patient discharge himself and come back with the drain in situ. That is amazing. Any questions for Dr. Smith?
The doctor, you use the product as well for autotransfusion, I think. I think you've shared a couple of times where that's been really helpful to have access to the patient's own blood. You find that
Absolutely.
beneficial?
Absolutely. And there was only about one patient, I think, it went to take the theater. But most of the patients, we auto-transfuse, most of them. And all of the doctors, know exactly how to use it. And I actually said to the team, we must actually throw away all that glass bottles in the hospital because it's useless. It's useless. No, we're very happy with the train. We're very happy with the train. The other interesting thing in terms of the shooting technique, I didn't know what this was the name, but I determined that how you fix a drain is called the Soweto fixing method. I don't know the other guys, maybe they've got another name for it. I think we all do the same sort of knot, when you tie the test drain. It's just way here from the other guys, but I was very interesting to know that it was based in Joburg. This is where they actually determine that this is the best suited technique to use to actually fix a drain, because it's obviously very important once you put in the drain to fix it correctly, because you don't want a drain to dislodge, or to get blocked.
Yeah.
All right.
Fantastic. Thank you so much, Dr. Smith. We also want to take the time to welcome Dr. Mayet from Khayelitsha Hospital. Thank you so much for joining, Doc. We are just at the point where we're sharing the cases, the interesting cases. Thank you, Dr. Smith. Dr. Lategan, you may share. Thank you.
I just want to know, can I do the share screen?
Yes, it should be enabled, Lamel.
Yes, doctor. Yes, you can.
It's disabled. Okay, so sorry everyone, I just need to try and figure out. If I did that, can everyone see that?
Yeah.
Oh, great. So everyone can see it.
Yes, yes.
Okay, so that was a case actually from Khayelitsha's side, that a patient that came in with bilateral gunshots that we inserted into costal drain. You guys can see the amount of drainage just in the one on the right. And then clearly he had one before, which you can see this is going into the arm. And then that's another one from the right going into the other arm. And he had a third drain. So those are a lot of drains, a lot of auto-transfusion. This was a Khayelitsha emergency unit before blood bank was on site. And possibly prior to us using freeze-dried plasma. So he survived, he did well. So he got his products back purely because of the ability of the auto-transfusion that we did there, which is interesting. At that stage, though, we were also using heparin. We were adding 1,000 international units of heparin into the drains, and then we stopped doing that. After a bit of research has shown we don't need to do that. So we don't do that anymore. Just want to show you another picture. So how do I exit this? Oh, did that work?
Let me see.
Does everyone see that one?
Yeah, see a chest X-ray.
Yeah, so there's a chest X-ray, 2 bullets, intercostal drain in. Again, this patient drained the same amount, more than 1,000 cc's, auto-transfused. What we're doing now in the tertiary hospital, which will probably come up in the questions, is that we hopefully only going to auto-transfuse one drain. By then we have our freeze-dried plasma or FFPs, we have our red cells or whole blood, and start with the blood products. So we try not to auto-transfuse more than one drain, as it were. That's essentially how we're working now. This guy, can everyone see that one? This guy had a lot of bleeding, and the problem here, so he had multiple, he had bilateral ICDs, 2 auto-transfusions were done, but there was a significant lung laceration which had ongoing bleeding. Unfortunately, he went to theatre and he had cardiothoracic surgery, which was great, and he did well. I've got some other cases. I just wanted to show you guys the same with your thoracotomies in theatre. We use the Sinapis for our front ring thoracotomies. And then I just wanted to show one more picture, if you guys don't mind. I can't seem to find that, I've lost it. But in terms of drainage, there. Can everyone see this video?
There we go, yes.
So there the effectiveness of the bulb is being demonstrated quite well, if everyone managed to see that. So I've got lots of cases, but those are the ones I'll show everyone. But the main thing is autotransfusion is good. We're using it. And one last thing I just wanted to show you, there's been studies in the US. So this is one of our local studies that we're involved with in terms of non-compressible torso hemorrhage and ICD usage. And then there's a lot of American interest around autotransfusion. Paper that's just recently been published, but what's interesting is that they've got data from many patients, but less than 1% of those actually had autotransfusion done in the US, whereas in South Africa, we're doing it a lot more. So I'm sure we're going to be getting a lot of interest from the US teams for more autotransfusion studies coming through. Okay, just get rid of that. Okay, that was my 10 cents worth.
Wonderful. Thank you so much for sharing, Dr. Lategan. From the panelists, is there any comments or any questions?
No, Doctor, I'm going to go again and ask you, we get the question often, how much heparin to add to the Sinapi chest drain? You mentioned that you started off with using heparin and then not. Would you, and this is, we get the question around a trauma case, an emergency case with a whole lot of bleeding happening very fast. And then obviously for thoracic or more so cardiac surgery, it could be different. But can you comment on why not using heparin anymore?
So we looked at some of the literature, and I see my boss is actually on Prof. Oosthuizen as well. He's probably more of an expert than most. So my answers must be good. So we started using 1,000 international units. We then stopped. We looked at very limited literature that was out there around 2018, 2019, which showed no difference. We did a small case study in our own unit, which showed no difference. I can pull that up quickly. The thinking is that in the bleeding state, as it were, you are slightly hypocoagulable. Therefore, there's no need for putting any heparin within the ICD. The other thing we just need to clarify, I'm sure through the rest of the webinar, is when to use autotransfusion anatomically with the injuries above the diaphragm versus below. Just when to make that decision, yes or no.
Sure.
Yeah.
Sure.
So hypocoagulation means that is it due to the flow of the blood? Is it, do you also have to consider rate of bleeding in terms of using heparin, or you're not, is that not clear?
It's not. I don't think we've got anything that's out there to show that. It's difficult in the thorax. What is the rate of bleeding? Do you have to look at output in the drain? 200, 250 mils an hour, but really your autotransfusion is not for the 250, 200 per hour, it's for the immediate. On drain insertion, you've got an output of 750 over 1,000 mils. That's immediate. Then we'll autotransfuse and then change it with another one. Can't really determine the rate of bleeding.
Well, that is a very fast rate. Milliliters per hour would be if that's a very fast rate. So in the fast bleeding, fast rate, high rate of bleeding, the heparin seems to not be necessary.
Yeah.
Awesome. Thank you so much for your questions, Chris. Thank you, Lategan. I just want to remind all the attendees about our questions and answers. Please post your questions in the Q&A section. We will address them. We look forward to those questions because remember, your questions are valuable and it might just trigger someone else would like to ask but doesn't have the courage. So I really strongly encourage you, please post questions. We will now move over to Dr. King. Dr. King, are you ready? Are you ready? Okay, the floor is yours.
In the case of commercial chest, you have autotransfusion. In fact, you actually autotransfusion with 2 minutes of your own blood. So, and it was all unilateral. And we actually tried another set of package trials together with EpiCare and given our
Dr. King? Dr. King, my apologies. The sound is extremely muffled and we cannot hear you clearly at all. Can we just double check your sound?
working.
No, not good.
Okay. Okay. We have to give me some time. Let me see. Hold on.
Now we cannot hear you at all, at all. Perhaps your headsets?
Some time to switch. Let me switch.
Okay, all right. Maybe just a little bit more volume.
Let's try that. Candice, otherwise, otherwise we can ask Dr. Mayet to go first, and we come back to Dr.
Yeah, I think that's a very good idea. Thank you, Chris. While we're sorting out the sound issue with Dr. King, please do not go anywhere. We've got Dr. Mayet online and he's ready to go. Thank you, Dr. Mayet.
Thank you so much. Apologies for joining a bit late.
No problem.
I'm trying to think back to the first time we've used auto-transfusion, and we've learned about it from our consultants. And of course, these things only happen once your consultant leaves and after hours. And the first time that I used it was in 2014. Where a patient came in penetrating chest wound and was pouring out of his chest. And we were at Heideveld Emergency Center, which is basically essentially a prefab building with no blood bank, no FTPs at the time. So then we were trying to figure out how to do, what to do, clamp the one tube, connect a new drain in, and then run the blood through the drip keeping set. And as Dr. Lategan did mention, we were not too sure at the time, but we were adding heparin. We were giving about 1,000 units of heparin through the or into the bottle or the chest box, and yeah, it worked well. It worked very well, and that has now become the norm, especially in areas where there is no blood bank available. We still do use it at Kalicha Hospital. not as frequently as there is a blood bank available, but we do it probably about 2 to 3 times a month. I think just the other day I walked in for the ward round and somebody was receiving the auto-transfusion. The only thing which was a bit annoying is that they leave the drain to swing about and they don't know about clamping it and connecting it and closing the drain. So I think if you go back to your units or if you are teaching the junior staff, just to make sure that the drain is clamped correctly and there is a cover on it or there is some form of blockage so that the old blood does not leak in other places. And often you have to place the drain quite high, which is in line with your eyes, so there may be a blood splash. But yeah, I've seen it save many lives, and the 1 or 2 which did not make it had severe non-survivable injuries. But it was a good teaching case for the junior staff. So and I think in our setting where we see a high prevalence of trauma, penetrating trauma, I think all our junior staff need to know how to use it and how to auto-transfuse patients. Nothing else I need to say. I was trying to look for the old photos on my phone, but there was a lot of photos to go through. But there are a couple of cases where we took videos on how to auto-transfuse. But for some reason it was too big, so I could not transfer it onto my laptop to show some videos. So hopefully at some point I will try it now and see if it does work.
Okay, awesome. Dr. Mayet, you want to try now before we give Dr. King an opportunity?
And I think give Dr. King an opportunity, and then if it does work, then you can come back to me. But I think the sizes were just too large of the files. It was like a 5-minute video or 10-minute video. So
Okay.
I think it's going to take up quite a bit of time
Okay,
to transfer
no
and
problem.
edit.
No problem. We can always make a plan. I can always get it from you and we can share it with whoever's interested in having that. Thank you so much for sharing those cases. I can hear that you've been using the drain for so many years. I think when we spoke, you mentioned the old Uster Hospital when that still existed. And it's amazing to see how the drain has also grown and developed and evolved with doctors such as yourselves when you were very young, when we just started in the system, and when you looked at the Sinapi drain and how simple it used to be. I mean, it's still very much simple to use, but now with all the extra features, that is really, really life-saving in your trauma settings. So thank you for sharing and thank you for walking this journey with us. Chris, is there something you'd like to add before we move over to Dr. King?
No, not at this stage, Candice. Great to hear. You never realized that it's life-saving. So it's a huge privilege again. And like I say, all hats off to you guys working on the front lines.
Absolutely. Thank you so much.
Yeah.
Thank you.
And then so just to go back to Dr. Lategan. In terms of, so we were trying to still figure out, and as he has mentioned, there's not a lot of data available on the clotting profile of the blood coming out into the tube. And apparently one of the theories is that the blood is void of clotting factors, if I'm not mistaken. But as was mentioned, more literature needs to come and become available.
Yeah, so Stacey just reminded me about the trauma-induced coagulopathy. So that's the thinking, is that because of the induced coagulopathy, there's no need to insert the heparin. because of that. We need to do some research on that. We have been thinking about it at Tygerberg. We're trying to get hold of a TEG machine to see if we can try and actually prove that decisively. Hopefully once and for all. We did a small little study. If I can I still screen share?
Yes, you should be.
This is, I don't know if you guys can see that. This we did at Candice, a little, the chest drains we used Auto-transfusion without the need to add heparin. We just did a small little cohort and we showed that it is feasible and that heparin is not necessarily needed. So that helped a lot.
That's a very good abstract. I remember when we not published, but when that was shown at one of the trauma conferences, it really had a lot of attention when it was exhibited. Thank you for sharing that abstract, Dr. Lategan. May we now move over to Dr. King?
Yeah, I should hope everyone can hear me now and hear me a little bit better.
Yes, a whole lot better. Thank you, Dr. King. Sounds awesome. The floor is yours.
Yeah, thank you. So look, my experience with it, we obviously have quite a big, large trauma area here in Tembisa Hospital. And yeah, about 2 weeks ago, we had another case of an auto-transfusion. In this particular instance, gunshot, left chest, a single entry exit kind of wound, but required 2 auto-transfusions. So he bled out a stat of 1,000 moles instantly, transfusion with that, and of course then another 1,000 moles came out. He required another packed red blood cell and 1 FFP, and then that stopped his blood. And I think what also needs to be considered is we have quite a delay of getting patients either into high care or into a ward or something like that in terms of monitoring. So he sat in our emergency department for the next 3 days, and we essentially monitored him inadvertently to see whether he was going to rebleed or not, and successfully so, he didn't rebleed at all. About day 3, in fact, he was ready to take his chest drain out almost in the emergency department. But having said that, we found space for him in the ward, and of course then he went to his normal observations in the ward. And he had a very successful outcome. So we're very good proponents of using autotransfusion. Yes, we do have a blood bank on site, but I think given our institutional challenges, trying to get even cross-matched or uncross-matched emergency blood is still a challenge. It'll still take us 10 minutes, whereas you can auto-transfuse immediately as soon as the 1,000 liters comes out, which if you can think of your junior doctors that are on the shift floor, that is very scary to them, for the uninitiated. And giving them the kind of power to actually retransfuse the patient with their own blood, is great for the patient and also great for the confidence of the junior doctors on the floor. I will admit, controversially, we are still giving heparin. There's a lot of controversies. I know trauma surgeons, vascular surgeons, everyone has a particular issue with regards to it. I think, to be honest, what saved us in this particular patient, and I've had the 2 extremes, is that we had 2 14 gauge needles in this patient, right? So 14 gauge, you're going to run in that blood. It's going to be quick. And I agree, if you've got such a large bore line and it's working very nicely, you're unlikely to need to use heparin. I've had other instances where if, again, you don't have a large bore line and you have quite a small line, and then the blood becomes stagnant. And in those particular instances, I've had issues where not all the blood was transfused adequately or timelessly within the particular patient. And through fault of whether you have heparin or not, blood has been unable to get into the patient in time. So hence the controversy of using heparin or not using heparin. But I'm glad to see that other people are not using heparin, because I think that deals away with a lot of the negativity towards using autotransfusion. And again, blood is scarce. Even if you do have a blood bank, it's still scarce, because to get cross-matched blood, just for the type, will take us 10 minutes. The only thing is uncross-matched, but because blood bank is so wanted to preserve their own eggs, they will gladly give you the O-pos, and then we just have to take the risk of whether you give uncross-matched O-pos, which may or may not lead to a transfusion reaction. But
because it's an emergency situation, we kind of have a little bit more leeway. And we find that generally patients do quite well being auto-transfused. And to be honest, it saves us a lot of hands for someone to run to blood bank, because it is on site, but it is quite far from where we are in the emergency department. Thanks.
Awesome. Thank you very much. Thank you for sharing, Dr. King. From the panelists, do we have any questions or comments for Dr. King?
So Dr. King, I'll go first, but it's actually a question to everyone. If you consider the positives and the negatives of blood from blood bank versus auto-transfusion, I mean, you know, for the audience, is it possible to share, you know, just generally, you know, what the pros and cons would be? Obviously, the one that you mentioned is the cross matching and the time it takes, and also the risk factor of transfusion reactions. You know, are there anything else? You know, the cost obviously as well. You know, what would your comments, anyone's comments be on that?
Yeah, so from a cost point of view, I think, yeah, sure. Look, I mean, the auto-transfusion is always going to be cheaper than buying blood, you know, whether using factory blood cells or whole blood, which is arguably even better, in getting FFPs, etc., and pooled platelets. So cost is one issue. A second issue really comes down to logistics. When you're having a polytrauma patient coming in, you know, you may not necessarily have the hands or even 10 minutes to spare to send someone to the blood bank to get it. We don't have a blood fridge within our unit that has a lot of regulatory burden. You've got to have temperature checks, you have monitoring, etc. So we don't have that in the unit. So again, we have to send someone out. So logistics wise, it's a lot easier just for us to auto-transfuse. Arguably, and this is why the patient received a factor blood cell. While you're busy in the mix, the first 5, 10, 15 minutes where a lot of things are happening at that time for that patient, it's easy to do auto-transfusion because you need all hands on deck to get up the lines, to get the pelvic binders, to get up all the paraphernalia that the patient has. And you can't necessarily spare even an intern to go pick up blood from the blood bank. Thereafter, once things settle down, patient is intubated, you've got both RPDs in, you've stabilized the bleeding, you know, you've stopped whatever source of bleeding you have, et cetera, and trying to warm up your patient. Arguably then, yes, you could probably send someone to the blood bank. And now you can ask for cross-match blood, et cetera, et cetera. But if you speak to blood bank, at least from our blood bank, but I presume it's the same, even if we were working in the private industry, to do just a standard cross-match, so a limited cross-match. In other words, you just want to know if it's rhesus negative or positive. That generally takes the blood bank, our blood bank, 10 minutes, because once they've identified the rhesus sign, they still have to print out all the stickers. And sometimes, as you may know, especially in here, we get a lot of unknown males that arrive here. So they sometimes will not issue a cross-match blood, even on the rhesus side, just because you have a known male. So again, that comes down to logistics. If you were then to go for fully cross-match, so now you want to know your row, your A, B, your positive, your negative, your row, your law, all those kind of antigens, that'll take them around 30 minutes. Now, if you have needing for the ongoing amount of blood, sure, then you can use fully cross-match blood. I think at the end of the day, depending on which level center you are, to be a level 1 trauma center, I think by 30 minutes, you should already be on your way to theater for damage control surgery. So then that's a matter really for theatre. But in the emergency department, where in the next 10, 15 minutes, I think time is of essence. Getting the patient stabilized using warm blood, because whatever blood we get, again, in our institution, we don't have a blood warmer. And if you are running high flow lines, you sometimes don't have the time to even warm up the blood because you're just throwing in blood. We know, look, there's another controversy as to you don't necessarily need to warm up your blood. But again, how many units of unwarm blood can you give to a patient before it starts in itself causing a coagulopathy just because of the temperature issue over and above the circulated blood and calcium? That's also part of the deadly pentad or triad, or depending which your state of view is with regards to hemostasis in a trauma patient.
If I can just add, unrelated to the whole, there's a movement now towards whole blood.
Yes. Yes.
So in Tigerberg trauma, we use freeze-dried plasma, whole blood, TXA, calcium. That's our standard formula at the moment. Whole blood is slightly cheaper. The terms of matching positive versus negative isn't too critical, and you can have fresh whole blood in a fridge for 28 days and less, although you prefer less than 10 days whole blood. So whole blood for trauma resuscitations can be easier logistically for the future, as it were. So, I mean, if that answers any sort of questions, it is a bit cheaper.
I want to quickly just add on as well to what Dr. King said. There's a video that we have from Mitchell's Plain trauma unit from last year that perfectly illustrates what he's discussed in terms of the timeline and the amount of people needed. I'm going to play the video, and you'll see as the auto-transfusion site is being readied, the whole process, the amount of hands needed in that case.
And also warming the patients, I see.
Yes, there are. And you can see the chest strain that they are using there. That is our latest version of the Sinapi chest strain, the level.
Thanks, Lemuel. That's good. So a question, what would the negativity be? What would the negatives be to use a patient's own blood? You know, what's the risk factor? I mean, you obviously are giving it back in through a medical device, and there's tubing, etc. So there's potentially a cross-contamination factor, or a contamination factor. I'm not sure if you give a routine antibiotic to mitigate that risk, but what in general would be negative to give a patient's blood back?
So that answer that. You guys, anyone else want to answer?
Andy, you go first, don't worry.
Yeah, the main thing is obviously is the Sinapi, is it sterile, which it does come in a sterile container. The lines, you know, was the arm, you know, cleanly swabbed. The other thing is in terms of diaphragmatic injury. So you could have diaphragmatic injury with bowel contents possibly going into the thoracic cavity, and then that being transfused into your veins, which is not optimal. So in terms of making the decision to auto-transfuse, yes or no, at least at Tygerberg, what we do is anything below the nipple line, yes in a male, different in a female. You need to look at the fold. Anything below the nipple line is not for auto-transfusion. Anything above is for auto-transfusion. So high thoracic stab, high thoracic gunshots. Consider it. Anything below, unless you're very, very certain that there's no diaphragmatic injury, which could cause contamination, don't do auto-transfusion. And we give 2 grams Kevsol as a stat on insertion as a single dose, which also helps. So what you guys do?
Yeah, so just from my side, we also do the antibiotics 2 gram stat. That's a general prophylaxis. That came out with the recent Cochrane review to show that that's just in general, whether you're doing auto-transfusion or not, just for putting an ICD. With regards to sepsis, yes, of course, I think we kind of look at the contents that are draining out of your ICD. If it looks like it's got fecal contents in it, it's probably not clean. You know, because if we have to limit our things over to the 4th intercostal space strictly, I think we would, we would be missing a lot of opportunities. So we kind of just on the macroscopic view. But again, yes, any thoracoabdominal injury is obviously of concern if you've penetrated the bowel. And again, obviously left side versus right side. But those are kind of the nuances. But in general, most of the times that we've done it, given the incidence of a thoracoabdominal injury is relatively low where we are, just because of everything is quite high up. We get more gunshot wounds than stab wounds as compared to down to maybe to the Western Cape. So we're a little bit more safe from that regard.
All right. Thank you, Dr. King. Thank you, Dr. Lategan. Before we move over to we need to move over to our questions. We've got a set of questions, and I think we'll just do about 3 of those, maybe 2 of those, and then we'll do the questions in the Q&A section. We are out of time. We've got about 10 minutes left. I don't know where the time has gone. I've had such a good time just listening to you and sharing your experiences that I've lost track of time. So, Chris, was there something you wanted to say before we move on to the questions?
Yes, Candice, I'm going to interrupt. There's one question I just want, from a practical point of view, I just wanted to ask you, we spoke about adding heparin or not, and Dr. King, you shared about the size of the needle to get the blood into the patient. Do you use the height of the chest drain as a guide? If you see that the flow is not fast enough, you try and lift the drain as high as possible. That's obviously, from a vertical or hydrostatic pressure point of view, quite important in our view. You've got to get through a 200 micron filter, plus then through the needle. We think the filter is obviously a big contributor to obviously filter the blood, but also slow down the flow. What's your experience in terms of trying to position the device high? Do you try and do that generally?
I mean, look, I think it makes common sense that given the higher the height, you should get better flow. Having said that, as you said, there's a filter. There's still the rheological viscosity of blood. And I think at the end of the day, you have some diminishing returns. I've seen some colleagues try to really lift the blood as high as it can, trying to extend it as high as it can. Really, it really has diminishing returns. And so I found that really the biggest and best thing you can offer is obviously making sure you have a large IV bore line to go through, because trying to raise your Sinapi thing, to the standard kind of 2 meter height, and then getting someone who's taller than 2 meters to then hold it even higher at like 3 meters, it doesn't really it doesn't go in any faster really. So I think again, if you could model it that really on physical principles, there must be a sort of diminishing return where going an extra 30 centimeters isn't going to have a noticeable appreciation in terms of getting your blood in faster, other than the narrowest point is obviously the filter, together with whatever IV set you've actually put into the actual patient itself.
Thanks.
Just remember, first prize is a central cordis line, subclavian.
Yes.
So those are the lines. Peripheral bilateral lines, yes, but a central cordis, large diameter, that's first prize. You wouldn't have to struggle to lift the Sinapi if you've got a cordis. And generally the standard of treatment now in major trauma centers is central cordis lines and bilateral, unilateral, wide bore IV lines. And that's how your fluid would run through.
Got it. Thanks, Doctor.
Brilliant. Thank you so much. Thank you for sharing. I'm really worried about the time now, Chris. We should do this more often. We should really get together more often and do this. Do you mind if we now move over to questions with everyone? Questions in the Q&A section. Okay. Right. So our firstly, there's a comment, Dr. Smith, that says, Dr. Smith, that is fantastic. That is a fantastic case with a fantastic product and a positive outcome. So thank you for that. Then we've got one, an anonymous, who says, according to the expert opinions, why is it not necessary to connect the Sinapi chest into a cell saver before transfusion back to the patient? And when will the cell saver be applicable? It's open to our panelists.
No. Yes. No. No, you want to go?
No, you can go. I was thinking we don't even have cell savers here at
exactly.
so we don't see the need for it. But I'm sure there's a better answer, a more theoretical answer, if you do have one.
Well, I mean, the point from my side is the patient is hemorrhaging acutely. The blood is pouring, you need blood straight in. And as Jonathan mentioned, there's delay from blood bank, etc. to products. It needs to go in now and right now. You know, the blood is still warm, hopefully. So it's not necessarily needed for a warmer. And that's the end of that, really. It's the life-saving procedure. Straight away, straight in, it's warm, above the nipples, you should be fine. And then call for your other blood products, FDP, FFP, whole blood, or packed cells products and platelets. And not forgetting TXA and then calcium, and you should be okay. So the cell saver doesn't necessarily, in that acute time, pressured moment, really go into the equation, and if not many people have them anyway.
Candice, last comment from my side. What we see in the market, we obviously sell in the trauma market, and we also, the same product is used after heart surgery and lung surgery, and this is more the place for the cell savers. Obviously in theatre, and from time to time we see hospitals and units take the cell saver out into an ICU, and then when there's a routine autotransfusion, there's a bit of a place for the cell saver. It's obviously, you know, washing the blood or getting it slightly cleaner, but I think as all four doctors explained today, this is an acute stage. Is repeating what Dr. Lategan saying, is that's the real benefit, is the benefit of speed.
Yeah, and also at first days, and also says that you only get your red cells from the cell saver. You don't get your plasma and platelet products. So you lose that coagulopathic profile, which is important. So that's also the problem.
Right.
All right. Anyone else want to comment on that question before we move over to the next one? We're all good. Fantastic. The next question is, can one do autotransfusion via an intraosseous needle?
Yes. I'm a big fan of IOs.
Okay.
You just, yeah. Look, I mean, I've had someone try and squeeze a Sinapi, but didn't work, obviously. So with the IO, remember the IO is very temporary. IO is your first line of call. You can't even get peripheral lines in. So the patient is so shut down, you can't get peripheral. You stick in an IO. It's very temporary. You just want to get the volume up to hopefully get two big peripherals or your central portus and then carry on with that. So it's possible, but it's not ideal at all. It's just get that volume up and then move on to your peripherals and central portus. It's possible, yes.
Okay, thank you so much. Thank you, Dr. Lategan. We've got the next comment and question that says, hi, thanks for this informative session. Can you confirm the correct procedure for clamping and disconnecting the chest catheter before connecting a new Sinapi chest drain? How do I confirm drainage after disconnecting the one that you want to auto-transfuse and then getting the new one on? And how do we now know this one is working?
That's a question for you, Candice, to answer as a product trainer.
I'm going to leave it for our panelists, Chris. I'm also here to learn. Dr. Smith, you're very quiet. Are you there?
Yes, there'll be a lots of simple procedure. I mean, once you change it, I mean, what I do, I would clamp the drain first. What I'm planning to take out, obviously, I try to be sterile all the time. And it's a very simple procedure. You just clamp and you change the dressing, you change the tubes, and you hang up your blood, obviously through a wide bore needle, cannula like discussed before. And to confirm that you actually have the right draining inside too, I will, after changing, I'll maybe will do an X-ray and mobile X-ray just to confirm the position of the tube. But most of the time it's very simple. It's not a big thing. You must just be sure that you are sterile, and this is basically what I do.
Right, yeah. So I think the principle is to continue draining from the chest, right? So you want to reconnect another drain. That's the
Sure.
Yeah. And I think if I may add to the last part of the question, where we can also, if you can see my drain, you can also use the bulb to confirm that the new drain that's been connected, that it's draining or it's working perfectly. Because when your bulb, I'll show you, when you've got an indented bulb looking like that, then you know something is not right. There's no air coming through. However, at that point, you want to see that your bulb actually re-expands. And once you have a re-expanded bulb, you know that your drain is working and it's air is passing through. So yeah, I hope that we've answered that question well. We have 2 minutes to go for the questions in the Q&A. We will respond to you, and we will share the Q&A everyone that is attended to. The last question: from what age would it be safe to do autotransfusion with a patient? Can one auto with a 16 to 18-year-old patient?
Yeah.
Yes.
Yes.
Yes, it's all around.
Yes, it's all around. Thank you.
Adult patient, so there's no issue to do that. And then I would definitely transfuse the patient at that age.
Yeah, most of the
Fantastic.
patients that
Brilliant.
I have done it is between 18 and 20 years. So
The young ones.
the young ones.
It's so good to hear. The young ones. Thank you so much for sharing. Thank you for the questions. We have probably a few seconds left. I promise we will do this again. Chris, you want to share the last few words before we do the closing and the vote of thanks?
Yeah, I'm so excited to have been able to listen to this, and just thinking of the need that, again, what we do in South Africa should become more of an example of what happens in the rest of the world. There are so many war-torn countries where the same, we might not, I mean, Germany's not going to have the same amount of trauma, not at all, but in some countries where patient mobility or patient casevacing or movement and autotransfusion or scarcity of blood is such an issue. So I'm just seeing an opportunity for more clinical research. I think that's we probably want to take up with Magda when she's around again, and Candice from your side is approach some of our panelists as well, and see if we can't do more formal research on the topic.
Definitely. I find that there's a need for that too. May we close off? Right. I want to thank each and everyone. I want to thank all our attendees, all our trauma doctors, trauma nurses, trauma staff, trauma surgeons, Dr. Lategan, Dr. King, Dr. Smith, Dr. Mayet, I've got all doctors here. I want to thank you, Chris, and also Gabriel. Thank you so much for your time. We really appreciate it. I found this very valuable. And we wish you well. We wish you a good World Trauma Day. Celebrate yourselves and celebrate the hard work that you do. And thank you for allowing us into your space. Thank you for being open to doing this and sharing your wealth of knowledge with others within our country as well. We are grateful for everything. Thank you, everyone. And I hope that you have a good day further. Thank you.
Thank you.
Thank you.
Bye-bye.
Cheers, bye.
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 Thanks, guys.